Purva, shall I start? Okay, good evening to all of you. Today I will start with an ultra short case first before going to the proper case. Are you able to see my slide?
Yes, sir. Yes, sir.
Yeah, so we'll start with the short case. This is a story of a 14-year-old man. This patient gave history of injury to the medial part of the left wrist 1 week back. In fact, he accidentally hit his wrist on a steel rod. Since then, he has noticed inability to bend the left little finger of the left hand. That is, his problem is he's unable to bend his left little finger, no other problem. So on examination, you find that his abductor pollicis is longus is normal. The interosseae were normal. The abductor digiti minima is also normal. Affection of the left hand. Let's start examining the flexor pollicis longus. But the other finger is normal, but the little finger is unable to flex the distal phalanx. So I fixed the middle phalanx and tried to flex the distal phalanx. Again, not possible, indicating the distal part of the phalanx is not flexing. Similarly, I fixed the proximal phalanx and the middle phalanx is also, middle part of the phalanx also is not flexing. So they fix the metacarpal bone and I had to flex the first phalanx. That was relatively good power. Unable to flex the little finger, the metacarpophalangeal joint, but not at the interphalangeal joint. The abduction was normal, digiti minima was normal, the palmar interosseae were all normal. Again, the interosseae is normal. Then the sensations were normal in both medial and dorsal aspect of the hand. No difference between the two. So on examination, she had weakness of flexion of the interphalangeal joints. Both the distal as well as the middle phalanx are unable to flex, but the proximal phalanx is able to flex at the metacarpophalangeal joint. Almost normal power of the metacarpophalangeal joint of the little finger. All other muscles are normal, including the flexor digitorum longus and flexor digitorum sublimus of all the other fingers. Sensations normal. So where is the localization? Probable cause?
So, probably a local etiology which affects the tendons of flexor digitorum crucialis and aciduria profundus, sir. Supplying only the little finger, sir.
Yeah, perfectly right. As you said correctly. So that means only it cannot be due to nerve involvement at all. It can only be because of the tendon injury. And that is because the flexor digitorum longus or the little finger and flexor digitorum superficialis or the little finger both are affected. But the flexor digitae minima is spared. That is hypothenar muscle is spared. That means this must be a long tendon is affected, not at the wrist joint. Okay, maybe at the wrist joint, but the tendon is affected and not at the hypothenar muscles. So this is the, what you said is correct. You can see this is the MRI of the wrist. This is a normal tendon which appears black. Here the lateral two ones. But the medial one is disrupted and it becomes hyper intense. That is a ruptured tendon which you see there, which supplying the little finger. In the axial section also you can find out there is a normal tendon seen there, but the ruptured tendon is medial to that. That is supplying the little finger. So it's a short case, as you said correctly. This shows loss of normal definition of flexor profundus tendon of the little finger, indicating a high-grade tear. He's also got a misdisplaced old fracture of the Hooker hamate. So that's only the prelude to the talk. So shall I go to the next one? Any questions in that case? It's an ultra short case. Okay. Shall we go to the next one?
Yes, sir.
Yes, sir.
Okay. So this is a story of a 31-year-old man. He gave history of jerky movements of the neck and upper limb noticed 6 months from the 6 months of age. He was born of full-term normal delivery, but of consanguineous parentage. He gave us to mild delay in all development milestones. He started sitting by 8 months, started walking by 2.5 years, and started speaking by 3 years. He was noticed a dragging of his left foot since the time he started walking. His walking difficulty, however, has been gradually improving since then, and he in fact completed his BCom and now working in Technopark. So in fact, his main problem is subnormal posturing of the hand and the jerky movements of the neck and upper limb. I'll show the video. He has now come at the age of 31. This all story dates back from childhood. Now this is the person. I asked him to speak. It's got mild dysarthria. Look at this face. Okay. You look at the shoulder also goes into jerky movement. There is no spasmodic dysphonia. Pupils normal. Ocular movements were all normal. There is no facial weakness. Tongue movements were normal. Look at the tone. I thought he has got something like a spasticity to the left. The pronators are more rigid or spastic, and the finger flexors are also spastic. Increased tone. The power, however, was normal. All muscles got a normal power. There was no finger nose incoordination. Except some abnormal posturing in the left hand, which you can see later on a little better. Keeping his hands outstretched, his hands caused some involuntary movement, some dystonic, acidotic posturing, and with occasional jerky movement to the shoulder also. See the abnormal posturing of the left hand. Lower limb tone appears slightly increased, more on the left side. Power, however, is normal. EHL power, everything was normal. Reflexes upper limb just elicitable. 1+ reflexes, not brisk in the upper limb. Lower limb, both knee jerks are brisk. Slightly more brisk on the left side. Hand jerk were normal. Abdominal reflex was intact. Plantar was flexible. Sensations were all normal. His rhombox was negative. This is how he walked. He has got hip to the trunk to the left side when walking. That's called abnormal posturing in the left hand. And left foot also goes into, it's got a striatal toe on the left side. So I think I will show the gait once again. The main findings were in the gait and the outstretched hands. Look at the left foot, it goes inversion, and then there's got a striatal toe also. The other part of the video which is to be observed is this outstretched hand. This also you have it dislocated. These are the two things which is abnormal, really abnormal in him. Neck, arm, it's got the occasional myoclonic jerks affecting the proximal part. And also look at the hand. So on examination, while speaking, he was noticed to have abnormal movements of the lips, mild tilt of the neck with occasional jerky movements of the face and the left shoulder. On keeping his both upper limbs outstretched, both hands would go into epitot dystonic posturing, more on the left side. So coming to the rest of the examination, trainers are all normal. There is mild slurring of speech. Motor, right upper limb, tone power normal. Left upper limb, there is spasticity. Actually, it is more in the pronatus and flexus, maybe spasticity, and rigidity in the pronatus and left finger flexus. Power all normal. TTR, both upper limbs, biceps, supinator, triceps, finger pressure just elicitable. Lower limb knee jacks were brisk bilaterally, ankle jack normal, abdominal reflex normal, plantar flexor. Sensory system normal. Gait walks with trunk deviated to the left with the dystonic posture in the left foot and also the hand. So what would you consider in this regard?
He has got
Mildly.
the mark. He has got dystonia and myoclonus. The dystonia and
Correct.
myoclonus combined, which is
Yeah.
born of a consanguineous marriage
Yeah, correct.
and delayed milestones.
Mild delay in milestones.
Mild
Correct.
delayed milestones. So, dystonia myoclonus complex, we should think first of a genetic disease, whether it is present or not.
But he has been having, he has improved remarkably now. He's going to the
Non-progressive. Non-progressive.
Non-progressive. He has improved actually. According to the mother, he is improved remarkably. And he's working in Technopark. And his spinal is asymmetrical, confined to the left side predominantly. Yeah, please.
Predominantly left side.
Yeah.
Sir, is it some form of extra, extra pyramidal cerebral palsy, which is improving static?
Yeah, right. Yeah, this looks like anyway not a progressive one. It is a static, even though it's born of consanguineous parentage, but his disease is gradually improving over time, and it's asymmetrical, confined more to the left side. So more like a dystonic cerebral palsy, or some kernicterus which has happened in early life. We do not know.
So we had a similar case. Where we had hemiatrophy of the face also, sir. Triplet syndrome, hemiatrophy, hemi-Parkinson, hemi-dystonia syndrome.
Right. Yes.
And did he have any atrophy on the left half of face or left side of upper limb to be examined in this patient, sir?
Correct.
And HI himself would be possible, sir, because it is static.
Yeah, that's the problem. But there was no history of HI. History was not there. But mother, there was a delay in all milestones. Initially, 1 month or 2 months delay, and subsequently 1 year delay. Subsequently became all right. Okay, so this is static encephalopathy, choredystonic CP, choreconnectors. This is what I would consider in the history itself. But there is an odd point, the consanguineous parentage may not be significant. That's because of the evolution of the history. So, in fact, he was seen in childhood by neurologist. And the investigation. Pardon?
Mr. Myclonus.
A myclonus is there. He had a myclonus now.
That usually not seen in CP.
That can put it. Myclonus can be seen as a part of seizure disorder. No? But moreover, any dystonia can be associated with myoclonus. Myoclonus and tremor are part and parcel of dystonic syndrome. So any dystonic syndrome can associate myoclonus, which by itself does not take away the diagnosis of dystonia. For example, if you get a spasmodic torticollis also, you get a myoclonic along with that. Similarly, writer's cramp also, you can have a myoclonic check along with that. So myoclonus and tremor does not, if it is occurring along with the dystonia, do not consider separate. If it is occurring in a limb without any dystonia, that becomes significant. Okay, he was seen in childhood by neurologists, and the investigative results are given below. At the age of 2 years, in 1995, they took a CT scan of the brain, which was within normal limits. Then his MRI was taken at the age of 6 years, that is 4 years after the CT scan. And his MRI was reported to show diffuse white matter hyperintensity chorioleukocystine. See, this is the MRI find. The film is not, unfortunately, I asked them to bring the film, but it is so long ago, it was not with them. So I only got the report is there. This is the report. Diffuse bilateral symmetrical confluent white matter lesions in the centrum semi-ovale and periventricular white matter, predominantly involving the frontal lobes, with sparing of the subcortical U fibers and myelin or basal ganglia. The above MR morphology is commonly seen in leukodystrophy. It could be late infantile metachromatic leukodystrophy. So this was the report which was which he carried with him. Okay, so they advised serum aryl sulfatase, so it was done. That value was low. In fact, it is 28.68. The normal value was about 50 to 200. So they say a mean value in 3 normal subjects say that the same day was 97.6. Then this report, this value is low, please correlate clinically. Then repeat aryl sulfatase done by our madam. It also showed 87.6, normal value 100 to 150 microgram. So patient is now 29 years and working in Technopark. To 30 near working Technopark. Now he has now come to you not for any disease. He has come to find out whether he has any problem getting married. Because he wanted to know whether his children will get affected by the same illness. That is why he has come to you, not for treatment. Because he has no other problem. He is going to work. So what do you think? What is your impression now?
Repeat neuroimaging, sir.
Okay. So repeat neuroimaging, what is it? I also thought we will do the repeat neuroimaging and asked them to bring the old film. They could not trace the old film. So repeat imaging was done now. Let us see if you can find any useful information from the imaging. This is the imaging. I will show the imaging. This is the T2. Look at the film very carefully. He has got periventricular hyperintensities. And that what it says, caudate is atrophied, putamen is atrophied. The caudate is also severely atrophied. There is some projection of the ventricular bone also. Now, this is the coronal T2. See, the caudate is not there, so rounded off, like Oscar appearance. That patchy white matter thing on the other side is the putamen, which is atrophied. That is a coronal T2. This is a sagittal cut. The corpus callosum is thinned out. Ventricles are dilated. This is the diffusion. Prayer sequence. Ensures periventricular hyperintensity. Raj, where? WA sequence. No evidence of any calcification or hemorrhage is seen. This is the T1. T1 was non-contributory. Saj, I think, will skip time. And the radiologist asked for a CT cut also for the completion's sake. The ventricles are dilated. What is see the caudate, severe atrophy of the caudate. This is the corresponding flare and T2. You can make out the hyperdensity in the periodic. So, what do you want to know? What is the diagnosis now?
Huntington, sir. Juvenile Huntington.
But he has got his complaints are gradually improving. He is cognitively well preserved. And more of chorea is got a dystonia that degrade.
Postsurgical.
Yeah, sequelae of connectors is a possibility you have to keep in mind. But he's also got in addition other findings. He has got preventricular hyperdensity is also there, and ventricular dilatation is there.
Huntington's disease-like illness, HDL.
Okay, but it's like it's improving, no? It's not progressing.
That is why
Starting from birth onwards, birth on with delayed milestone, and he is now at 29.
Carnivorous plus hypoxic ischemic encephalopathy.
Yeah, that's a good possibility, some static encephalopathy. In fact, I did not know the diagnosis, but diagnosis is there. I'll come later on. In fact, another madam who saw the patient earlier during childhood, when he saw him coming back and asking for his marriage, she was surprised. Initially, I know the metacarpal leukodystrophy is now coming walking like this. So she sent the patient to me. That's how I saw the patient. This periventricular hyperdensity is there. Again, I show the pictures. The cardinal finding I will show. Then white matter hyperdensities. It's also got prominent Sylvian fissure. You know, the arrow is wrong, that's on the other side. And putamen atrophy. Putamen is so much atrophied bilaterally. And caudate atrophy. And putamen atrophy. So this is the findings. Diffuse cerebral atrophy, bilateral periventricular white matter hyperdensity, bilateral caudate and putamen atrophy, bilateral posterior putamen left cingulate gyrus hyperdensity. So, any thoughts now? In fact, genetic test was done here now only last month. It came, the report was no pathogenic or likely pathogenic variants of causative of the protophenotype detected. This is what is the report. But subsequently, one more additional report was there that surprised me. Additional variant stable. I don't ask me about all these things. I only know they returned the GCDH one, that is Glutaric aciduria type 1. Autosomal recessive, likely pathogenic. Can this be a glutaric aciduria type 1? Because I also not seen a case of glutaric acid type 1 before. So I searched the literature that can go with our patients. Now read the literature, this can exactly fit in with glutaric acid type 1 because the presentation is highly variable. It can acute presentation with subsequent static course. I'll read the literature part of it. It's a disorder of lysine, hydrolysine, and tryptophan catabolism caused by deficiency of glutaryl coenzyme A dehydrogenase. Acidic type 1 is autosomal recessive disorder, is caused by pathogenic variants of GCDH gene. Over 200 variants associated with GA have been identified. This is highly variable clinical manifestations. It usually presents with an acute encephalitis-like encephalopathy in infancy and childhood after a period of normal development. Untreated, approximately 90 patients will develop an acute crisis, or often precipitate gastroenteritis, intercurrent febrile illness, immunization or surgical intervention between 3 and 36 months of age. The characteristic neurological sequelae is the complex movement disorder due to bilateral striatal injury. Dystonia is the dominant extrapyramidal symptom. Some patients may additionally develop spasticity or a kinetic or rigid Parkinsonism. A few patients with insidious onset and late onset types of GA1 have neurological injury without any encephalopathic crisis. So this is from the literature, the prominent Sylvian fissure, which our patient had, but not as prominent as this one. The acute phase, there can be abnormal hyperdensity in the basal ganglia. Now our patient had a it has gone on to atrophy. Abnormal increased signal white matter, which our patient had. This is again white Sylvian fissure and white matter hyperdensity in 8-month-old neonate. The early phase, you find hyperdensity in the basal ganglia with swollen basal ganglia, which later on goes into atrophy. So that's the story. So going back, this patient might have had an acute encephalopathic illness underlying this glutaric aciduria 1, which resulted in the striatal injury and then remain like that without any progression. That's also well described in literature. They can remain without progression. So that's the story of this patient.
This patient has some asymmetry on the left side is more affected.
Left side more affected. But what I said is correct. Right side is also there. Left is definitely more affected than the right side.
So what about, can he marry? And he
Definitely,
claims that.
No, I said he can get married, no problem. Because it's autosomal recessive, no? So if he should only think he should marry from his, relative side. It should not be consanguineous marriage on his part. If he can marry someone else, then it's no problem. So I never knew this diagnosis. That's why I thought I in this case to you. So this can present acutely in childhood and remain like a static encephalopathy. So that's a lesson I wanted to tell you regarding this case. So any questions before I go to the next one?
A similar presentation can occur in legs up, like acute presentation, then remaining static in leaks disease.
Leaks usually they can also present like thiamine division can also present acutely, like encephalomyelitis presentation. In fact, the old term for LACE was subacute encephalomyelitis. But usually, subsequently, if it is untreated, they tend to progress. If it is corrected, proper thiamine division is corrected, the pyruvate deficiency is corrected, then they can remain static.
Why was this aryl sulfate is low? Any guess?
No, I don't know. That is the initial report they came, but it was not very low. It was 90, 100 and upper limit 100, this is about 90 something. Not very grossly low. See, the fact that aryl sulfate was a SEN showed that patient had bilateral hyperintensity in early time, like mimicking leukodystrophy. So the report was correct. Because since it has gone on to atrophy and the ventricle got dilated, that periventricular white matter hyperintensity is not that very prominent now.
Usually, you'll be seeing that Sylvian Fisher dilatation is the most prominent thing, no?
Yeah, correct.
Initial scan was not showing that. That may be the reason why.
You're right. You're right. So again, if you look at the literature, see, that need not be there all the time. See, this with a particular patient, see, silver dilatation is not that very prominent. Not all cases may not show that thing. But that is said to be the characteristic finding. But many other cases which I searched the literature, that was not there. It's not a must. And as you said correctly, that is the reason why it was diagnosed as MLD.
Any treatment given for this patient now?
No, what the literature says that avoid protein containing lysine and all, but that's not practicable. But they advise carnitine. So I prescribed in carnitine. Okay, shall I go to the next case? This is a story. Pardon?
Adult onset BTBGD also this type of presentation, sir.
Adult onset?
BTBGD, sir. Biotin time and response to basal ganglia.
Yeah, right. But they have got a characteristic finding, the hyperintensity in the basal ganglia and thalami and all, and bilaterally symmetric subcortical white matter hyperintensity, like a patchy, not like this. This is a diffuse white matter hyperintensity. In basal ganglia disease, you got a patchy hyperintensity, discrete patches hyperintensity.
Okay, sir.
This is a story of a 65-year-old lady. I have seen first in March 17th, that is this year, March. In fact, she had complained of, has been having radiating paresthesia from the left side of the neck along the lateral border of the left upper limb for the last 15 years. And also radiating pain along the same distribution for the last 10 years. She noticed a swelling in the left side of the neck above the clavicle for the last 1 year. Till that time, she was only having this pain and paresthesia. She was going on work without any problem. A surgery was done for the swelling 2 weeks back. Since then, immediately following the surgery, patient noticed difficulty in elevating his left arm, and bring her hand towards her mouth. So that's the story. But a swelling, and when removed, he developed a weakness of the left upper. So this was the mass, the ultra resolution thyroid and neck sonography. Mass in the left lateral neck as described, and enlarged lymph node. So they took the tumor that turned out to be a schwannoma, a neurofibroma arising from the neck. So this is the video of the patient. Examined a no Horner syndrome. That's the scar of the operated site, exactly on the region of the brachial plexus. Tone was, shoulder shrugging was normal. Deltoid was weak. You cannot hold it against cavity. Almost 0, say 1 power. Flexion also is 0 power. Plexus was normal. Brachial is also grossly weak on the left side. He cannot hold against cavity. Just 1 power. Pronated teres was normal.
That's good. This pronated teres is good.
But supination was weak on the left side. Yes, I expected. He cannot keep it supinated.
That is good.
So the dose pressure there is normal, finger extents normal. Finger flexors are all normal.
അടുപ്പിക്കാൻ സമ്മതിക്കില്ലേ?
Small muscles of the hand normal.
പിടിച്ചോ.
Common side negative.
മതി വിട്ടു. ഇതും പിടിച്ചേ.
Lower limb power normal. Come to the reflexes. Right upper limb reflexes normal. Left upper limb all reflexes were absent. Even though triceps power was normal, that also little less on the left side. Could not elicit on the left side. Both knee jerks are well elicited. Plantar downgoing.
ഒരേപോലെ അറിയാവോ?
Come to the sensory system.
ഒരേപോലെ അറിയാമല്ലോ. ഒരേപോലെ അറിയാമല്ലോ.
It is same on the hand.
ഇപ്പോഴും ഇതും വ്യത്യാസമുണ്ടോ? വ്യത്യാസമില്ല.
It is normal.
കരയോട്ടില്ല. ഞാൻ ഈ കുത്തുന്നതും
But all the deltoid region, there it is less on the left side. Only over the deltoid area. Joints is normal, vibration normal. So to examine the serratus anterior and this, that's normal, normal part of the serratus as well as that is normal serratus.
ഉള്ളിലോട്ട് തള്ള, അങ്ങോട്ട് തള്ള.
External rotatus by weak on the left side. That is on the right side. That is grossly weak. Internal rotatus by normal.
അത് തന്നെ. ഇനി ഉള്ളിലോട്ട് പിടിക്കുക.
That is weak. So if you got operation scar in the supraclavicular area, cranial is normal, motor right upper limb all normal, left upper limb shoulder shrugging normal, weakness of the left deltoid, biceps, brachioradialis, external rotatus almost 0 to 1 power. Triceps, wrist and finger muscles were all normal. Lower limb stone power normal. Detail left upper limb, biceps supinated, triceps finger pressure all absent. Right upper limb all normal. Again, just elicitable. Lower limb all normal. Impaired sensation over the left arm, left upper arm. So where is the localization and what will you advise this patient? All this followed following a surgery.
Upper trunk of brachial plexus on the left side.
Very, very good. Upper trunk. The site of lesion is upper trunk of brachial plexus. So what will you advise here? Or you have to do some investigation, you can say some investigation.
MRI with contrast to look for any fibrosis or any lesions.
This happened immediately. 2 weeks back surgery was done. She's coming here after 2 weeks. Invariably, there will be some hypernecity will be on the operation site.
NCS we can do, sir. Initially NCS.
Yeah, right. We can do the NCS to find out the degree of damage. Okay. So the question now is, was it a complication of surgery, like injury to the upper trunk of brachial plexus? Probably the schwannoma was originating from the upper trunk. Or was it a totally unrelated problem like neurologic chemotherapy? But it's coincided with the operation. Anyway, what do you want to do? Okay, this is the NCS. This is the median. Pardon?
So it can be the neurologic chemotherapy also, the post-anesthetic local installation that can also cause muscle.
Yeah, that may be correct. That's in operation is one important cause of neurologic chemotherapy. I've seen immediately following cesarean, following this thing. I've seen this thing. Okay, let us see. So what do you want to do now? The nerve contraction was done. This is the median, and we are not interested in that thing. I'll skip that thing. But the radial was normal. Left axillary and right axillary almost normal. 15 on right side, left is 11. Muscular cutaneous nerve also normal. It's a normal motor conduction, even after 2 weeks. Then suprascapular nerve also, compared to the right and left, marginal difference, otherwise normal. FAs were no, that is not important because the nerves which are affected does not, has no value for FA now from the other nerves. So sensory potential, left radial normal, and the nerve we are interested is what? Which nerve we are interested in now? It is the lateral cutaneous, lateral antebrachial cutaneous nerve. That is normal. Because we are dealing with the upper trunk. The sensory nerve arising from is the musculocutaneous. So that means you have to look for only nerve we are interested is the musculocutaneous. So that's nerve was normal. Now what do you think?
It could be proximal to the site of stimulation, sir.
Yeah. Right. So what is the likely etiology you will consider now?
Maybe some anesthetic, allergy, something like that, which could.
Demyelinating block.
Yeah, but what is etiology, likely etiology?
Demyelinating, sir.
BP exchange related demand.
Like due to what? Demyelination secondary to what?
Chemical injection.
I don't know whether chemical injection was given at that site. Again, chemical
Give
injection
local anesthetic
will not produce a selective demyelination like that. Very, very unlikely. That produces axonal damage. You can chemical injuries, chemical is injected to that.
Positioning of the arm during surgery might have triggered nerve edema.
No, very unlikely. See, if you look at the situation, it is in the upper trunk, the supraclavicular area, but the positioning is not unlikely to affect that area. Again, zero power of all those muscles supplied by that.
Can it be some vascular cause because neurofibroma, schwannoma can cause abnormal
Right. Yeah, that agreed. But only thing is that why should produce nerve conduction abnormality like this? Vascular all compromised axon, no? Why should it produce only something like a demyelination? Okay, what will you advise now?
MRI, sir.
MRI, it's not going to help us anyway. You find a scar there, you know there is a tumor there.
So what about the dorsal scapular as well as the long thoracic nerve?
That from there clinically normal. See, I checked the serratus sinus. You saw me examining. Serratus sinus is normal. Trapezius is normal.
MRI including spinal cord, will it help, sir?
No, it is because site of lesion is at the upper trunk. Because it's not a radiculopathy there.
ENG.
Your point is valid because sensory potential is normal. One can consider radiculopathy proximal to the ganglion. But the CMAP amplitude is also not affected.
EMG will help.
EMG may not help because your image is going to shed innervation. Or you can differentiate demyelination versus axonopathy, but no evidence of axonopathy electrophysiologically.
So we have to do a MR with contrast to look for the proximal part of the brachial plexus. Proximal part.
The site of abrasion is certain, no, it is upper trunk. It is not proximal to that. Because the long thoracic nerve and other things are all spared.
Any chance for anterior horn?
Chance for?
Anterior horn cells, ischemic.
Yes, but she is complaining numbers of the deltoid also. But if interconstal also, you should find a decrease CMAP amplitude, acute onset, after 2 weeks. But anyway, so I think it's borderline, just 2 weeks. Sometimes you have to wait for some more time to find out proper electrophysiologic abnormality to appear. It usually may take up to, say, sensory potential become abnormal after 11 days. It's nice CMAP after 1 week, it should be abnormal. If done after 2 weeks, theoretically expect axonopathy should produce decrease CMAP amplitude. So what will you do?
EMG, sir.
EMG, I did not do the EMG because I didn't think it was going to help. Okay, you can differentiate axonopathy. Again, EMG finding, no, it will not appear in 2 weeks' time. It may, because the last thing to appear in the innovation is the EMG finding. May take as depending upon
Any
the
in-
distance of the site of injury. Pardon?
Any inching technique, would that do any help, sir? Proximal.
No.
No,
We have no
condition
doubt
block.
about we have no doubt about the site of lease. Inching techniques is for the site of lease.
MRI brachial plexus, sir.
Okay, that was also suggested. So now what I did was I put her on, we made that prednisone because I thought this is most likely to be neurology chemotherapy because see, you cannot have an injury to the thing without any axon, same application. It's very odd. So again, so I put there, this is what I did. So I called her after 2 weeks. And 2 weeks later, after using, there was no improvement at all. Zero power.
പൊക്കാനല്ല ഇല്ല ഇനി ഇങ്ങനെ വെച്ചിട്ട് ഇങ്ങനെ അടുപ്പിക്കാൻ നോക്കിയിട്ട്
Again, biceps zero power.
ഉള്ളോട്ട് എടുക്കാൻ നോക്കും
Triceps is normal. External rotatus is again zero.
അകത്തോട്ടെടുക്കും ഇങ്ങനെ കൊണ്ടുപോകാം നോക്കിക്കാൻ
Other muscles are same, exactly same as before.
മടക്കി വലിയ മടക്കി മടക്കിയിട്ട്
The reflexes are all just like before. Sensory system also findings remain the same. That now it's become 1 month now.
എല്ലാം
Now she's telling she's got numbers of the thumb. I'm not very sure.
ഇത് ഒരേപോലെ അറിയാവോ
She said it is sensation in the thumb. I don't know as to the underrated finding or not. It was not there before.
ഇതും ഇതും അവിടെ
Now she has got numbers of the teeth.
അറിയാവോ കിഴിയിരുത്തം കുറവ്
But vibration, everything was.
പഴയ
So re-examination of 2 weeks of IVMP for 3 days, then oral steroid. Then now it has become totally 1 month now. Remains the same. She now has sensory dulling of the left thumb. Now what will you do? I repeat the conduction. So this way our industry areas industrial conduction was done. The left axillary potential was initially it was little more higher. This is compared to the right. This is 10 now. Muscular cutaneous is almost again little less, but not more than 50%. She's got a zero power, but still it is. This cannot explain that. Suprascapular nerve almost normal. Depth suprascapular. This is 8, only 6. Marginal decrease. Sensory potential continue to remain now. So what will you do now? Continue steroid, stop physiotherapy, continue physiotherapy, or wait for some more time. So I asked you to
Wait
continue.
for some more time, sir.
Pardon?
Yes, sir. Wait for some more time, sir.
Okay, waiting. So she was asked to continue physiotherapy, followed up 1 month. Then, so this is the 1 month means, you know, it was 6 weeks now. This again 1 month after the previous one. Again, same, no improvement.
ഇതിങ്ങനെ പൊക്കാൻ നോക്കിക്കാൻ തോള് പൊക്കാനല്ല പിന്നെ കൈ ഇങ്ങനെ ആക്കാൻ നോക്ക് വെളിയിലോട്ട് ഇല്ല ശരി ഇനി കൈ അകത്തോട്ട് മടക്കി
Again, same. And the bystanders were firmly believing that it's all following surgery.
വിട്ടേമ്മ
It is a surgeon's fault which has caused this problem.
ഇതിനകത്തോട്ട് തള്ള മുറിക്കത്തിരി ഇത് രണ്ടും അറിയാമല്ലോ ഇതും ഇതും
Same finding as before. No change in the findings. I just find out the CMAP, I did myself. The CMAP would elicit from the deltoid. So what do you think? You're asking me whether she will ever improve. real practical situation, no? A surgery, exactly the same site, patient come with weakness immediately following that thing. And there is every reason for the bystanders to believe that all following surgery. What did you do?
Patient will improve, sir. Naturally, the natural history is that she should improve. So we'll continue physiotherapy. In the meantime, we get a MR also, sir. MR.
Okay. No, I said that I did not do it. I said that she just wait, she will improve.
Continuous.
Because, and I said that she'll definitely improve because it is not an axonopathy. Even after this much of, say, 6 weeks have passed, still there is no axonal change. Same happened relatively, not even less than 50%. So that means she has to have a conduction block proximal to that. So they said, what made with books, I'll come to that later. Despite a severe weakness, 100 parameters were normal, demanding the proximal to the site of stimulation. Mostly it must have been some neurologic chemetropy. So that's what I told her. Then I called her after 3 months. Don't come now, you come after 3 months. So she came after 3 months. That's now this is the power now. She has delta is improved. It is not totally big power. Biceps is much better. It has become great too now. She can do that now. Initially, it is not at all possible. External rotation is also good. External rotation is also good. Not fully, but better than before. So all weak muscles improved to 2 plus to 3 than from the initial grade 0. So in such a cases, now when you find the electrophysical parameters suggest demyelination, just follow, they will improve. And as somebody was suggesting, neurologic chemetropy can follow immediately following surgery. I have seen a road traffic accident coming with brachial plexus injury, something mimicking injury, but turned out to be neurologic chemetropy. What precipitated that, I don't know. What precipitated here the demyelination, I don't know. But this is well known, well described. Okay, any questions? I will show another case. This time we find muscular, there is some decrease in the amplitude of muscle cutaneous, otherwise not. Now, this is a similar case, but not exactly similar. This 35-year-old man had clavicular fracture and was put on a steel plate under local anesthesia. Following the surgery, he noticed him able to lift up his left upper limb. He had no weakness prior to anesthesia. This is the video of the patient. He had no wasting. See, deltoid was relatively good power, 4 plus power was deltoid. But with biceps is grossly weak, he cannot even hold against gravity. Is weak. Brachial is also weak. He cannot hold against gravity, falls down. See, his coracobrachial is relatively okay. And keep it flexed position, he cannot keep it, the shoulder flexed. But abduction normal. The shoulder flexion is weak, but abduction is normal. Triceps is weak. Finger extension is 0 to 1. Wrist extension and finger flexion also 0 to 1. He cannot extend. Finger flexion again weak, but little more powerful than the finger extension is. Abductor pollicis longus was also weak. Extensor pollicis longus also weak. He cannot hold it against cavity. Only again. Flexion was relatively good, 3 plus power. All small muscles are also weak. The reflex in the left upper limb all were diminished or absent. Sensation was over normal, except that, no, not normal. I think it was, I'll tell you, I think it was normal. I'll show the finding later.
ഇതും ഒരേപോലെയാണ്.
ചെറിയൊരു മരവൊക്കെ
He was decreased in the left arm, lateral
ഓരോ
aspect of the
ഭാഗം
palm.
കൊണ്ടുവരും. ഇതും തമ്മിലാണ് സെയിം. ഇതും തമ്മിലാണ് വ്യത്യാസമില്ല.
ഇത്ര വ്യത്യാസം തോന്നുന്നില്ല.
He was decreased in the lateral aspect of the arm, it was decreased. Our radius now.
ഇവിടെ കുറച്ച് ഇന്റൻസിറ്റി ഫീൽ ചെയ്തു ഇപ്പൊ ഇതിനകത്ത്.
കൂടുതലായിട്ട്
കൂടുതലായിട്ട് ഒരു സെൻസിറ്റിവിറ്റി കൂടുതൽ തോന്നുന്നു.
ഇതും
അവിടെ കുറച്ച് സെൻസിറ്റിവിറ്റി കൂടുതൽ ഫീൽ
He feels more on the left side.
വരച്ചിട്ടില്ല. ഈ കുത്തുന്നതും ഇതും
Equal.
ഇത് ശ്രദ്ധിച്ചോണ്ട് ഇപ്പൊ എല്ലാം തോന്നുന്നുണ്ട്
വൈബ്രേഷൻ.
അതേമാതിരി ഇവിടെ ഉണ്ടാവും.
ഇല്ല.
He's not feeling the vibration there.
ഇവിടെ
ഇല്ല.
All the fingers, there is embed vibration.
ചെറുതായിട്ട്
ഇത് നോക്കിക്കേ. ഈ വെച്ചതും ഇതും
വ്യത്യാസമുണ്ട്. ഭയങ്കര കുറവാണ്.
It is decreased on the left hand.
ഈ വെച്ചതും ഇതും
സെയിം.
That is same.
അറിഞ്ഞൂടാ. ഇത് അറിഞ്ഞൂടാ.
He does not. JPS was also embed.
പഠിക്കും തോന്നുന്നു ഇപ്പോഴാ
മടക്കി തോന്നുന്നു.
It is embed. So the findings: confined to the left upper limb, deltoid grade 4 to 5, coracobrachialis grade 2, biceps supinated left shoulder adductors grade 1 to 2, brachioradialis grade 2 to 3, triceps grade 3, left wrist and finger extensions CHL grade 1 to 2, finger flexors all small muscles grade 3 plus to 4. All absent in the left upper limb, normal in the other limbs. Sensory touch pain normal. Impaired, in fact, pain was little less on the outer arm. Impaired vibration JPS on the left hand, all the fingers. So where is the localization?
So the muscles involved once more.
No, I'll tell you. I'll show the muscles. One of the interesting finding was his deltoid was good power. He could hold, but he cannot flex the elbow. That part, I'll just show that particular video once again, just for compare. See, deltoid power is good. See, he's good power. But subsequently, biceps also weak. It goes into pronation. That means biceps supinated is so weak that one is a pronation. Brachial is also weak. You cannot hold against cavity, just weak. And forward flexion is weak. So you cannot keep it straight from forward. It goes outward. It goes outward. You cannot keep it against cavity. Deltoid, however, is strong. All of the muscles were also weak. So this is the muscle weakness. So where is the right side depletion and take etiology in this session?
So pan brachial flexitis, sir.
Nothing to do with the surgery?
No, sir. Very unlikely, sir. May be related, but unlikely, because considering the whole group of upper middle and lower tragus affection, that too in a patchy manner.
Yeah. The point is very strong. What is a strong clinical point favoring your possibility?
The upper part of the trunk is not involved. Deltoid is normal.
Correct. That's the point. See, not upper trunk is not involved. It is involved, but a patchy involved, as Murray is telling. See, the coracobrachialis is weak. He cannot hold against gravity. But deltoid power is normal. How can it occur with a trunk lesion or a nerve lesion? Only possibility is that can occur only with a nerve lesion. You got the point? See, the axillary nerve is good, but the musculoskeletal nerve is so much affected.
Yes, sir.
Okay, that cannot occur with a injury to the brachial plexus by any means. That means the pattern is the distribution of multiple nerves. That gives the clue that's more likely to be neurologic hematrophy. That's the peculiarity of this. It does not confine to the exact distribution of a trunk or root in neurologic hematophy. This point I have told many times before. Sometimes you find that only the deltoid and external rotaries are affected. Biceps will be entirely no. Biceps will be weak, but brachioradials will be no. Because biceps is separated by the musculocutaneous, brachioradials is radial. That is why most of the brachioradial, some of the neurologic hematophy, even biceps is weak, but brachioradials is fine. That tells you it is not exactly something like a structural or a cut injury or a mass lesion affecting the upper trunk. It is picking up certain nerves within the plexus. And that pattern is very strongly favoring a neurologic hematophy. So this is one important finding. It's very clearly seen. You cannot forward flexion is weak, but abductor is. How can it possibly with the upper trunk? Okay, so what do you want to do? Look for serratus anterior weakness. To rule out radiculopathy. That is normal.
Keep it up.
External rotation is also normal. It's not external rotation, trapeze is also normal.
Then that one.
So NCS was done after 12 days. This NCS. What do you find?
Left median CMAPs are reduced, sir.
The CMAP is okay, 9.4.
The right side, it's 18, no, sir.
Let me see. This is all done on the left side only.
Sir, the
18,
lower-
18. 18, okay, 9 point, correct. It's mildly decreased, correct. More than 50% decrease is there, correct. But more importantly, what do you find?
Musculocutaneous axonal patterns.
Okay. But there is only one site of stimulation. But look at the other one. See, it's got inelicitable EBS point. It's 9 millivolt is there. It is inelicitable. Here, ulnar 10.5 inelicitable. Okay. That shows it's got a block there, conduction block. Okay. The axillary is also decreased compared to the right side. Right side it is 16, gives us 5 point. Even though it is clearly good power, that is less decreased amplitude. FAV is normal, sensory potential is normal. Even though he had got impaired posterior column, sensory potential are normal. Why they are normal? Why sensory potential is normal?
It can be normal, sir. Sensory may not get affected.
No, it's affected. He has got impaired vibration joints of all the fingers. He did not tell Janapage at all.
So distal, no, octodromic conduction.
No, the answer is very simple. He has got a demyelinating block. No, where is the block? In the brachial plexus. You are stimulating the sensory nerves distally. So snap is going to be invariably normal. You got the point? See the block, where is the block? See the motor point, see it's in the EBS point only. Below that is the CMAP relatively good size. See the ulnar 10.5. That was his peak. So that tells you that the lesion is in the upper part of the plexus. So all sensory potential are doing distal to that only. It's not an axonal injury, it's a demyelinating block. So snap will be invariably normal. In that case, you have to do an SSCP to find your abnormality. If an H reflex equivalent is there in the upper limb, they can do that. So that's a sensory potential. These are all things will tell you that this patient has got a good chance of recovery. It's going to be demyelinating block. Even though it's got a zero power, almost zero power, it's good chance of recovery. Shows conduction block. The fact there is gross disparity in the CMAP amplitude of the axillary and biceps show that the lesion is in the plexus, not in the roots. Why the snaps are spared, I already answered that thing. Because the stimulation site is still to the site of conduction block. So I will give an IVMB, and this is after just 3 weeks. Biceps has improved. Biceps is good power. Initially zero resistance, now has become better now. Wrist finger resistance are not that improved. Other things are all improved.
ഈ ഫിസിയോതെറാപ്പിയും ഈ ഇതൊക്കെ ചെയ്തോണ്ടിരിക്കുമ്പോൾ കുറച്ച് ടയർഡാണ് മസിൽ. ചില സമയത്തൊക്കെ ലിഫ്റ്റ് ആവുകയൊക്കെ ചെയ്യും.
I followed him after 2 weeks, 2 months, he has totally improved. The weakness totally improved. So this again, so these things you should keep in mind. If you find something like following surgery, it will be erroneously attributed to the trauma or the surgery. But always look at the conduction. If you find demyelinating there, you always give a good prognosis. Okay, any questions?
Why were the FAs normal, sir?
FA, let me see. Yeah, because we are doing from the median and ulnar, no, that much more less affected. Let me see the FA latency. FA is not affected. Usually we don't do FA from the axillary or musculocutaneous, only done from the ulnar and median. That may be less affected. That is maybe the reason. Because the small muscles are not that much affected.
We could have done for radial, sir, because the wrist extension was affected. Radial FA could have been.
Radial could have been. Again, you must remember that, see, the FA latency, we are only measuring the FA latency. If there is a partial involvement of the device, suppose you have got this point also I told sometime before, even in demyelinating lesion, you can have a normal FA latency because, see, imagine you've got 10 fibers. Out of the 10 fibers, 8 fibers have got demyelinating block. Your amplitude will be low. Will have sensory loss. But the 2 fibers which are left behind may conduct normally. So you get a normal FA latency. So in that situation, you have to look for the FA persistence and chronodispersion. Then only you can find out the abnormality in the proximal abnormality in the proximal part of the nerves. That is, a many time in your GBS, you may find FA latency may be normal. Patient may be having weakness. Because all the fibers may not be affected.
Yes, sir. Okay.
So shall we stop or go for one more case? What do you think?
One more case, sir.
Okay, one more short case. Okay? Just short case. This is a story of a 52-year-old female. She noticed slowness in walking for the last 2 months. In fact, she had an episode of fall while going down the slope 2 weeks back. She came to be walking normally. I did not even think that she has got a problem. But this history gave me a clue there is something wrong with her. Notice paresthesia of the both feet for the last 1 month. Again on leading question only. Again on leading question, she said precipitancy. On examination, you find the tone power normal in the upper limb, no abnormality. The lower limb, there is a mild increase in the spasticity. I do not know, but being a female, they may not fully relax. But the power was normal. Lower limb power, proximal power, distal power was normal. The reflexes, however, was upper limb normal. Lower limb knee jerks are really brisk. That is really brisk compared to the upper limb. Analytics are also normally acceptable. Plantar was indefinite, neither upgoing nor downgoing. Sensations not normal, but she had impaired vibration of the toes. Joints are normal. She's correct. This is how you walked up is almost normal, but then I walked and walked fast. Then look at the abnormality when she's made walk fast. See the right gland is become slightly spastic now. On walking fast, you find the right lower limb is dragging. Initially it appeared normal. Look again the right lower limb. See that one. See that one is the spasticity developing when walking. The fact that she fell down on climbing downstairs also is indication of spasticity of the lower limb. So findings confined to the lower limb. Spasticity both lower limb right more than left. Normal power of lower limb detail, all normal in the upper limbs. Lower limb disc ejects and inject normal. Abdomen reflex normal. Sensations impaired vibration of both feet. JP's sensation was however normal. Spasticity of both lower limb walking fast more on the right side. So where is the localization?
Above L1. Above L1.
Yeah. Above, so you want, is it thoracic cord, brain, paracentral region, or in the cervical cord? Which area would like to image first?
The dorsal cord, sir. Dorsal.
Dorsal cord. So MRI dorsal. This is the dorsal cord. This is the T1. Okay, also the T2 axial. This is C7 D1 area, D1 D2, D2, D2 3 normal, D3, D4, D3, D4, and D4 on the right side. All appears normal. But D4 and D4 5, there is some hypointensity anterior to the cord. Again, you can find out that thing here on on the right side, you can see the hypointensity anteriorly. Again, C5 says you can see that below that it is D6 onwards, it is normal. D6 or D7, 8, no compression of the cord. D8, D9, D9, D10, and corners, okay, normal. So what is the diagnosis now?
Segmental OPL, sir.
Very good. Perfectly right. What will you like to know how to prove your point?
CT of the spines.
Right, very good. So this is abnormality. See here, if you look very carefully, you can find something there occupying that area. This is abnormality there. Marked hypointensity. That means it's by the calcification of bone. So this is the CT scan. Did you see the abnormality? The long calcified posterior longitudinal ligament. See, the point is that I have never seen OPLR confined to the dorsal thoracic spine. Usually find in the cervical, but here cervical spine is entirely normal, only confined to the dorsal. That is OPLL, segmental OPL, as you said correctly. It is compressing the cord.
Can this be skeletal fluorosis, sir?
No, here actually the ligament is calcified. Fluorosis can also produce calcification, but this is if my memory is correct, I only in Chandigarh I saw the stomach fluorosis. There the typical calcification, the anterior interosseous membrane of the forearm. In the spine, they produce fluorosis, produce skeletal hyperdensity. The ligament, I do not know. Maybe you may be right, but only confined to the posterior ligament is very odd for fluorosis. I'm subject to correction, I'm not very sure. But anti-dorsal calcification is very typical. That I have seen. Again, fluorosis is very, very rare in Kerala. We never see fluorosis here.
Sir, why was the worsening with walking fast?
Now, this is again another phenomenon which we find in spine, in personal spasticity. When they walk fast, they develop more stiffness. The people will tell you that thing. Initially, I do not know what is the explanation for that. There was some explanation which I cannot remember now, but I'll find it and later tell in the next class. But this is thing which very often people will tell. That is why they got more problem in walking down the steps in spastic people than upstairs. And again, when they walk fast, the limb becomes more spastic.
Sir, is it something like a Utho phenomenon, something like that?
No, not like that. They don't develop paresthesia or anything. Only stiffness become more. Weakness also will not develop. Only stiffness, they will become more stiff on prolonged walking. That explanation I have to search and let you know.
So is it velocity dependent?
Yeah, in fact, if you get a velocity dependent, agreed with you, it'll be. But the point is that after a period of increased velocity, it will comes down. But in lower limb, it's applicable. I do not know. When the pronator is a pronator catch, after the catch, the tone will come down. That is why the velocity, it becomes increasing during the initial phase, then comes down. Probably that's a good explanation which you think is correct. Probably the velocity is increasing, producing more stiffness. Maybe. That may be a good explanation. What actually happens is that when you do the checking the spasticity, the parameters, if you do first 2 frames, the stiffness will be there. If you do repeatedly, the spasticity wanes off. No, this I have told you, when you look for spasticity, the parameter spasticity, do the initially full quick supination, you find the pickup catch. Do it second time, you may get a catch. Third time, fourth time, if you do repeatedly, the catch will disappear. Then make the patient rest for some time. Then do again, you can find the spasticity appearing. So that is the usual spasticity, pronator catch you get in pyramidal spasticity. Probably you can explain that way.
So how was she managed?
Surgery. With surgery. Because it is anyway going to, it's already producing compromises spinal cord is getting. So thoracic spinal canal is very narrow, no, unlike lumbar region. So we know there is a small, even if the ligamental calcification is less, it's going to compress the spinal cord.
Sir, it may be easier to do posterior decompression in thoracic than anterior.
Yeah, because the anterior decompression will be very, very hazardous and difficult.
Yeah.
They require thoracic surgeon and all. The posterior decompression is easy for them.
Yes, yes.
So is there any spinal cord atrophy at that point?
He had. I'll show you. I'll show the atrophy part. Yes, the sagittal cord. See this one. The cord is slightly. See, this is the one. No, cord is slightly atrophied. Again, you see, you can find some compromise in the atrophy, spinal cord atrophy there.
So there can be additional ischemic changes as well, sir.
With that, we have no clue. Only thing is that only spasticity is there. No other evidence of any cord compromise. Atrophy can occur due to compression itself. Okay. So shall we go for today?
Okay, sir. Thank you. Thank you very much, sir.
Thank you, sir. Thank you,
Thank
sir.
you.
Good night,
Thank
sir.
you, sir. Thank you, sir.
Next week, same time.